speaking today on Dequervains Tenosynovitis. Again, a very, very common thing that you all will see in your daily practice. I'll quickly take you through the introduction, anatomy, clinical features, variations, investigations, treatment and complications. So it was first described by the Swiss surgeon Fritz Dequervains in 1895. There are various names to it, and now if you go on Google, you will find all kinds of names like gamer's thumb, ninja thumb, blackberry thumb, iPad thumb, and all kinds of names. It is basically a group of disorders now which are known as RSIs or repetitive stress injuries, which have come into vogue because of this IT profession. People spending a lot of time doing the same repetitive activity causing micro injuries leading to a variety of situations like carpal tunnel, Dequervains, tennis elbow, so on and so forth. Etiology, it is a tendon entrapment or tenosynovitis is the first dorsal compartment. As far as pathology is concerned, we do not know exactly what it is, but definitely it is not an inflammatory pathology. It is more like a myxoid degeneration and fibrous tissue deposits in the tendon sheets of the first compartment. This deposition, fibrous deposition, leads to thickening of the tendon sheets of the APL and the EPB, which are housed in the first compartment, and hence the gliding of these two tendons becomes painful, and hence the symptoms. You all know about the extensor compartments. You have 6 compartments, out of which the first one houses these two tendons. Epidemiology, more common in females than in men. More common people who are prone to other such disorders like tennis elbow. Bilateral involvement may be seen, and very commonly it is seen in lactating mothers who are just, have had childbirth. It is either because of that position of lifting the baby's head, or it is because of a condition of fluid retention, because fluid retention itself can cause such kind of problems. Anatomy, you all know, you have the first compartment, and then you have this compartment can be as long as 2 centimeters, and you have the tendons along with their sheaths gliding through these tendons. Repetitive and sustained tension on these tendons produces friction at this rigid non-compliant sheath, and hence you get pain whenever the tendons glide there. This first compartment probably has more variations in the upper limb than any other part. There are so many variations. There are some studies which say that as many as 35% of people will have a different structure in the first compartment. So you may have 2 different compartments for the APL and EPB. The APL itself may be bifid or 3 slips. It may have attachments to the radial styloid separately. There may be more than 2 septations. Various types of variations can present, and you have to be watchful of them when you are treating them, because if you don't pay attention to them, you are likely to fail in your treatment. Clinical features, pain in the area of the radial styloid, a little proximal to the radial styloid, which is aggravated by any movement of the thumb. There are various tests that are described. The commonest we all do is the Finkelstein test. The concept is to ulnar deviate the wrist, and then, after having ulnar deviated the wrist, to put the thumb into adduction or extension to stretch those 2 tendons, and the patient gets a pain which is similar to the pain that he has come to us for. Then you have the Aishoff stretch, which is a small variation. See, there are various tests, but they are all small variations of the same principle to tension these 2 tendons and see whether the same pain is reproduced. Then you have the Watt test, which is a wrist hyperflexion test, where you completely hyperflex the wrist and then you ask the patient to forcefully abduct the thumb. Investigations wise, very often it's a clinical diagnosis, and actually you don't need an X-ray for the diagnosis. But in private practice, please always ask for an X-ray, although you know it will be normal, because rarely there can be surprises. And I have had a case where it was actually a GCT and I was thinking of it was as a Dequervains. So surprises can occur. Do ask for an X-ray. Ultrasound is of course the gold standard for diagnosis. The ultrasound can pick up the quality of the tendon sheaths, the fibrous canal, whether there is any fluid collection, edema, and so on and so forth. You don't need it in your routine practice, but sometimes if you are not very sure or the patient is a little complex types, it's better to do an ultrasound and confirm a diagnosis. MRI, of course, is the most sensitive one whenever you are in doubt. It's not really required in a primary case, but yes, if you have treated the patient, if you have operated and it has failed, then an MRI will come to your rescue and really tell you whether you have missed anything. So there are various signs that you can see on an MRI. I will not go into them. There are few differential diagnoses which appear or which mimic Dequervains, which you should keep in mind while diagnosing a Dequervains. And the first one is an intersection syndrome. This is, when you get pain where the muscles of the second compartment, the ECRL, ECRB, cross the muscles of the first compartment. If you see the anatomy, the blue lines, these are the ECRL, ECRB, and the red and yellow lines are the muscles of the first compartment. They cross about an inch prior to the extensor retinaculum. And sometimes due to hyperuse of the thumb or the wrist, this intersection can be painful. If you are not vigilant, it may appear like Dequervains, and you may end up injecting it, which may be false. So the tenderness is proximal in the blue area compared to the yellow area of the Dequervains. Then you have the first CMC arthritis, which can also be very, very similar in clinical presentation. The tenderness is a little more distal, and the grind test, which you always do, where you actually compress the metacarpal against the carpus and then rotate it and generate the pain. Then a scaphoid fracture also can mimic similar pain. It will be in the anatomical snuff box, a little distal, but keep that in mind. And last but not the least is the Wartenberg syndrome, which is a painful neuroma in the superficial branch of the radial nerve, which can occur because of some trauma or people wearing some tight wristwatches or tight bands or something. They will have pain, which is more of a neurological pain in the area of distribution of the superficial branch of the radial nerve, which is marked here. And a Tinel sign may be positive there, which is the pathognomic way to differentiate between that and a Dequervain. Management, of course, in most cases, it has to be conservative. You have to really spend time with the patient and tell them and counsel them that someday it will go away. It will take few months, and you have to live with it. Icing helps a lot. You can give them splints to be used periodically so that the thumb is rested. Counseling, you can send them to a physio for ultrasound, this, that. We really don't know how much it helps, but like all other enthesiopathies or tendinitis, this is self-limiting and someday it will go away. You just have to encourage the patient to wait till that time. If not, then you have two other options. One is an injection and second is a surgery. In injection, we all know we inject corticosteroids. We have always been doing it the blind technique where you ask the patient to extend the thumb, look at the APL and EPB tension, they stabilize with your hand, and you enter from more distal. The needle goes in from distal to proximal at an angle of about 45 degrees. You hit the tendon, you pierce the tendon, feel that resistance. Sometimes, you like the trigger finger, you can ask the patient to move the thumb and you can feel the needle moving. But then withdraw it out of the tendon and inject into the tendon sheath. And very often the patient might get good amount of relief. Nowadays, of course, we have started doing it ultrasound guided. So it can be done ultrasound guided. The accuracy is more, it is more predictable, although it takes a little effort because you have to go to the ultrasound clinic since the ultrasound no more is portable, and sterility is a little doubtful, but it definitely looks a lot more trendy, and of course the results are also predictable. So you can see here the needle is actually going, and you can see that these two compartments are separate. The needle is individually injecting both into that. Right? Now, few complications you should know about injection, and most important is this extraversion of the steroid. Because in this young females, who have just delivered, you inject steroid, and some steroid is extravasated into the subcutaneous space, they may have whitish discoloration of that area, which can really look shabby. The patient can be really upset about it and chew your brains. Most often it goes away. There are certain creams which the skin guys give for pigmentation, but till such that time it goes away, it can be really a pain for you. So once you are in the tendon sheath, you inject it. Please do not keep injecting till your needle is out. Just stop injecting and bring it out so there is no extravasation that happens. Surgery, of course, we all know it is done under local anesthesia using a tourniquet. You can take a vertical incision or a transverse incision. The vertical incision is, of course, the better one for beginners because it is along the length of the tendon. It is along the length of the superficial radial nerve. So you can see the nerve better. You can see the sheath better. The only problem is that it is at right angles to the Langer's line, so the scar may not be good. And hence, most people prefer to use a transverse incision. You take the skin and subcute. Once you have incised the subcute, stop using any sharp instrument because the nerve is going to be there. Only blunt dissection after that. First, identify the nerve, safely protect the nerve, then identify the two tendons, excise the sheath, and spend time in ensuring that the tendons are completely free along the length of the sheath. Both the tendons you can individually visualize, and you're not missing on any aberrant slips or aberrant septae. So this is quickly a transverse incision. You can see now he goes on to now blunt dissection. You can find the nerve there in the upper part of the incision. You isolate the nerve, free it, and then you can retract it. Once you retract it, then you are safe to address the other things. That's the sheath being identified. The sheath is being incised from distal to proximal. The incision has to be on the dorsal surface. You should not incise the sheath on the ventral side because then you may end up in causing subluxation of the tendons. So you incise them on the dorsal side. Once you lift both the tendons nicely, freely, and see that the entire, the length of both the tendons are completely visualized. Some people will excise a part of the sheath like they do in the trigger finger. I don't think it is required. And once you've done that, just close the incision, give them a compression dressing, and encourage them to move. Quickly, there are 2-3 main complications of surgery you should know. First is injury to the nerve. Hence, pay extra attention to the nerve. Do not use any sharp instruments there. Second is releasing on the volar side, which can cause subluxation of the tendons. And third is, of course, a wrong diagnosis. So if you not diagnose yourself correctly, surgery may not give the relief that you desire. Thank you.